Most people in this room probably know Francisco Durazo, who was on faculty at USC, on faculty and medical director of the liver transplant program at UCLA, and now is at Medical College of Wisconsin in charge of the liver transplant program on the medical side. And we're really pleased that he came back here today to speak for us. I will say I'm sure he's a little bit disappointed that it's kind of chilly here. He probably was expecting a warm day, but in any event, he's going to be talking about abstracts on liver transplantation from AASLD. Okay.
Good morning, everybody. Thank you very much for having me in this meeting. It's really an honor and really nice to be back in warm California among colleagues and friends. So I'm going to talk on the abstracts on the AASLD, and at the end I added a small addendum on a special meeting on liver preservation. I hope you enjoy it. Nothing to disclose. The first abstract is the multi-organ dysfunction and evaluation for liver transplant model. There's the model score. This is to predict 1 year post-transplant mortality in the sick patients with acute on chronic liver failure. The main author of this abstract was Dr. Vinay Sundaram. Rest in peace, a great doctor, colleague, and friend. Well, we know there are the two important conditions in patients with chronic liver disease. One of them is acute decompensated cirrhosis. It's bread and butter. Ascites, GI bleeding, hepatic encephalopathy, or any combination. The other one is acute on chronic liver disease, which is a syndrome associated with short-term death in patients with decompensated cirrhosis. However, it's a recently described syndrome, and I must admit that initially it took me a while to get acquainted with acute on chronic liver failure. Remember, first time a fellow told me, Dr. Durazo, you know this patient, I think he has acute on chronic liver failure. I said, acute on chronic, have you been drinking? So now looks like there is enough body of literature to support the existence of this syndrome. However, still there are a few that don't believe it exists. It has three major characteristics. Occurs in the context of intense systemic inflammation, develops after precipitating events. The most common that we see is acute alcoholic hepatitis, and it is associated with a single or multiple organ failure. There are three grades. Grade 1, it's a single organ failure, most likely renal. Grade 2, two organ failures or any combination, and grade 3 or more organ failures of any combination. So what question is, should we do a liver transplant in these patients? There has been a lot of debate due to the scarcity of donor organs and the potential high risk post-liver transplant mortality. So what they did here is they develop a tool to determine the 1 year post-liver transplant mortality in these sick patients. Multi-center trial, 15 centers in the United States, and they came up with predictors to determine 1 year mortality. They used different methods to make sure that the performance discrimination and calibration was fine with the model, and they selected based on performance and simplicity. There were 735 patients. 521 had severe ACLF, 237 with the ACLF2, and 284 with ACLF3. The median age was 55-year-old. The male sodium at transplant was 40, so sick patients. 104 patients, almost 20%, died within a year. Using logistic regression, they came up with the following variables. If age more than 50 years old, the presence of one or more vasopressors at the transplant, the presence of respiratory failure, and history of multi-drug resistant bacterial infection. Then they run all these through different tests for good discrimination, calibration, and performance. And basically, what they came up that a score of 0.43 predicted mortality of more than 30% within a year after liver transplant, with a specificity above 87%, and a score of more than 0.66 predicted more than 40% mortality in 1 year after liver transplant, with a specificity above 94%. Then they compare the model score with the different types of males, the male sodium, male lactate, donor male, the delta male, etc. And if you see the AUROC of the model score, it performs better to predict 1 year post-transplant mortality compared with the different types of male. That was statistically significant. So I think it's a good start, needs validation, but it would be great to have a tool to predict the mortality in these sick patients. We are seeing more and more frequent ACLF. And the thing is, should we do a transplant? And I think would be a good tool to determine futility in this situation. The next abstract is on the HCC markers, AFPL3 and this gamma carboxyprothrombin in patients with HCC on the liver transplant list, looking at tumor progression. We know that an elevated AFP, when has been associated with significant worse in post-liver transplant outcomes. But also, on the other hand, more than 30% with HCC do not have an elevated AFP, but they have other positive markers for HCC, such as this gamma carboxyprothrombin and AFPL3. So what they did here, they looked at all these markers, looked at tumor progression in patients with HCC on the liver transplant list receiving liver-directed therapy. And they look to identify factors associated with increased time to progression between liver-directed therapy and liver transplant. So they had 126 patients, and they had 4 groups. One of them were all triple negative markers, AFP negative and DCP or AFPL3 negative. The second group was AFP positive with a negative AFPL3 and or DCP. The third one was AFP negative and DCP and or AFPL3 positive. And the fourth group is the one that had all positive, AFP positive and DCP and or AFPL3 positive, 29.4.7. Then they did a univariate analysis that showed that the ones that had an AFP positive with AFPL3 and or DCP had a much higher progression. That was statistically significant. And the ones that had AFP only, they had a slower progression risk. Also, time to progression was much lower in the patients that had AFP positive and with AFPL3 and or DCP positive compared with the other groups. You can see on the graph all the different groups. The one AFP with AFPL3 and or DCPs, the lower graph, you can see worse outcomes if you compare it with the different groups. So I think looks like AFP, AFPL3, and DCP, in my opinion, they have been around for a while. They have been underutilized, but they seem to be a good independent prognostic tool to look at the progression of HCC in patients with liver transplant. Probably we might use them, we might start changing our therapeutic strategies in these patients. The next abstract is on terlipressin, the new kid in town, recently FDA approved, has been shown in European trials to improve renal function in some patients with hepatorenal syndrome. This is a post-hoc analysis from a 12-month follow-up in liver transplant recipients that were included in the CONFIRM trial. They were patients with hepatorenal syndrome treated either with terlipressin plus albumin or placebo plus albumin. And they looked at the incidence of hepatorenal syndrome reversal, for need for renal replacement therapy pre and post-transplant, and also overall survival even 1 year after transplant. They had 300 patients in the CONFIRM trial, terlipressin 199 versus placebo 101. 70% underwent liver transplant, 43 were treated with terlipressin, and 27 with placebo. Hepatorenal syndrome reversal was seen in 37% of the patients treated with terlipressin, 15% in the ones treated with placebo. And overall survival at 1 year post-liver transplant was higher in the patients treated with terlipressin than the ones treated with placebo. On the right, you can see that pre-transplant patients treated with terlipressin required much less renal replacement therapy compared with placebo. And at day 90 post-transplant, you can see even still the requirement for renal replacement therapy is lower, and 1 year post-transplant also. So suggesting some improvement in the renal function in after transplant. If you compare it with placebo, its behavior is very different. So it looks like pre-transplant terlipressin has decreased the need for renal replacement therapy pre and post-transplant. And also the renal replacement therapy has required less frequently at 6 months and 1 year post-transplant, suggesting ongoing improvement of the renal function. Terlipressin decreased the worsening hepatorenal syndrome and increased overall survival. Next abstract is FENOFIBRATE improves cholestasis in liver allograft ischemic cholangiopathy. We know that ischemic cholangiopathy is the Achilles heel of liver transplant. It occurs around 15 to 20% and causes allograft failure in a significant number of cases. So what they did here, they used fenofibrate to treat 10 patients that had ischemic cholangiopathy. They were recipients from a DCD donor. So they treat 90 days, once a day, maximum dose, 160 milligrams a day. And all the patients received the standard of care, including ERCP with stents, etc., during fenofibrate treatment. All the patients were transplanted from a DCD. and warm ischemia time was 24 minutes, cold ischemia time 6 hours. Ischemic cholangiopathy was diagnosed with ERCP. So you see the first graph up on the left, it's alkaline phosphatase. You can see that it starts going up, and when fenofibrate, that's where the line is, then you can see alkaline phosphatase starts to go down. The next graph is bilirubin. Also, there is some mild improvement after fenofibrate. The graph on the left below, there are 3 types. They divided the 3 types of cholangiopathy. One if progressive, the other one was the dominant stricture type, and the lowest one is the minor form. And you know, all the 3 types of ischemic cholangiopathy started to show improvement of the alkaline phosphatase after fenofibrate. And the graph on the right and below shows patients with ERCP and without ERCP, treated with ERCP and stents. And you can see that in spite of ERCP, alkaline phosphatase continued to improve after fenofibrate. Fenofibrate was stopped in 1 patient at 60 days due to worsening jaundice. So I think this is the first demonstration of first pharmacologic intervention to improve ischemic cholangiopathy in liver transplant patients. I think it's exciting. Needs further studies, validation, but if it works, it would be really great even to use it as a prophylaxis in patients that are getting DCD liver transplants, to look at the utilization of ERCP or retransplantation. So I think it's exciting. I think all agree with me that liver transplantation has been a pretty successful treatment for end-stage liver disease. It has been done all over the world. You can see the numbers on the graph. Every year, more and more liver transplants are being done. Also, increased of liver disease has also increased the demand. So this success has triggered an insatiable worldwide demand for liver grafts. The single most important factor limiting the success of liver transplantation is organ shortage. So this has triggered different strategies to decrease the gap between available grafts and the need for grafts. And this has been using marginal liver grafts or extended criteria grafts, as well as accepting donors after circulatory death. And this has become more and more frequent. Here we see all the DCD liver transplant performed. We can see that every year we are probably less strict in regards assessing a donor, and we are accepting more and more marginal or discarded livers or with extended criteria and DCD. And now we know that the old ice bucket, the one that we used before to harvest pristine organs, now it has become obsolete. Before it worked fine, but now it's not good enough to handle these marginal liver grafts. And now we have required more sophisticated methods to handle these organs. This is the normothermic mechanical perfusion machine, just recently FDA approved. This abstract shows the impact of normothermic mechanical perfusion in a liver transplant center. where they had a high volume of DC liver transplant. This is from the Mayo Clinic. And they looked here at outcomes and hospital resource utilization. It's a single center cohort study. They looked at all the liver transplants done in the first half of the year. And they looked at the normothermic machine perfusion liver transplant versus static cold storage or the ice bucket. And then they looked at the different grafts subtypes, the DCD and the DBDs. They had 33 DBD liver transplants and 57 DCD liver transplants. Normothermic mechanical perfusion was utilized in 48 versus in 10 DBDs. The mean donor age was higher in the group that was treated with normothermic machine perfusion. The allocation mailed at transplant was 23 only. Wow, nice number, very different from the one that probably you see here in region 5. But important that the normothermic machine perfusion was associated with lower odds of early allograft dysfunction compared with the static cold storage. And also in the DCD group, the early allograft dysfunction was less frequent in the patients treated with normothermic machine perfusion compared with the static cold storage, and it was statistically significant. About costs, well, total operating time was shorter in the normothermic machine perfusion. It was also less intraoperative and total blood product transfusion in the patients treated with a normothermic machine perfusion. Median hospital length of stay and readmission was similar in both groups. So looks like normothermic mechanical perfusion has been showed benefits, especially in the DCD group, showing decreased early allograft dysfunction. And also it showed some improvement in operating time and decrease in blood transfusions. So this is on a special meeting that took place also at the AASLD. It was the industry colloquium where perspectives and advances in liver preservation. There was a lot of discussion there. Different modalities for liver transplant were presented. So first one was a debate about machine mechanical perfusion. Is it normothermic or hypothermic? Which one is better? Well, some say, well, hypothermic is better, cold is better for the mitochondria, cold might decrease HCC recurrence. The normothermic ones say, you know, wow, cold is not physiologic enough. So there was a debate, but on reviewing 3 randomized controlled trials, they showed that both of them show benefit in reduction in acute liver injury, reduction in post-reperfusion syndrome or cholangiopathy, that was significant. Also increased duration at preservation, a better assessment for organ viability, and increased organ utilization. However, and there is no head-to-head comparison, randomized trials not suited to compare technologies that make different claims. They also showed that long-term normothermic machine perfusion, this is being very popular in Europe, and it has a lot of advantage. Actually, most of the transplant programs were very happy with this. First, expands the assessment of viability. You can go look at the organ for a while and see if it's a good organ to do a transplant. You can also, while you perfuse the organ, you can do ex situ liver regeneration with nutrients. Not only that, if the liver is too fatty, you can do liver defatting. And also, this changed the logistics in the liver transplant programs because all were pretty happy with this. Because you, for example, you can go harvest the organ, connect it to the normothermic machine perfusion, play around on golf, and go next day, come and do your liver transplant. So they don't need to do in the middle of the night, call the anesthesiologist and come, let's do the, they can go, they take your time, do it electively, anesthesiologists have a good night's sleep, and we'll do the transplant tomorrow. Don't rush, oh, what? No, okay, let's do it easy. So that has been really a pro. The recent publication, transplantation of a human liver following 3 days of ex situ normothermic preservation, 3 days, and over a year follow-up, the graft is completely normal. So this has been now very popular, especially in Europe. And now there are some countries that they prohibit doing a DCD donor liver transplant if you don't have a machine perfusion. So if you want to do a DCD donor, you would need to have a machine perfusion. And there were also several modalities. Now the new one is combined. You can start first with hypothermic for 1 or 2 hours, and then you switch to normothermic for 1 or 2 more days. And during this time, you can measure flavin mononucleide and different parameters to look at organ viability. How about xenotransplantation? Also, there was a lot of on this. We know that Dr. Leo Makauka, probably you met him, did the first one at Cedars-Sinai, heterotopic pig liver xenotransplant in a patient, in a lady that had fulminant liver failure for autoimmune hepatitis. The patient didn't get any organs, so he decided, okay, let's do a pig liver transplant. So the patient survived for several days, however, later developed severe acute cellular rejection. However, now with the CRISPR genome editing, we can now treat the pigs to decrease the antigenicity of the liver. And this has made the use of pig-to-human xenotransplant possible. And actually, there are already 3 groups here in the United States that move forward with trials in human subjects, University of Maryland, New York University in Langone, and University of Alabama. How about also there were 2 groups there about 3D bioprinting livers or hepatorganoids. The one that you see down there, it's a 3D printed liver. And studies have shown that they acquired liver function. They have albumin secretion, the cytochrome P450 drug metabolism, even glycogen storage. Not only that, they develop vascular systems also when formed after transplantation. Studies have been done right now in mice, especially keeping mice with acute liver failure alive. So these 2 groups were really working on this, and we'll see probably a few years ahead, but it's exciting. How about bioengineered livers? Also, this is another one. This is from Myromatrix, a company in Minnesota, working also strong to create bioengineered livers. And the way they create this is first they take a pig liver, they decellularize the liver and take the scaffold, and then they repopulate this scaffold with human hepatocytes, and there you go. You have a liver. There are several studies that are being done right now in pigs with fulminant liver failure, with good results, keeping them alive. There was a lot of group from China doing the same thing. So it's exciting. The bioengineered is done as an auxiliary liver transplant. So you do first a portal-cable shunt, and then you do the transplant underneath the native liver. And last but not least, it looks like the traffic, especially you know here in Los Angeles, it's not getting better. And that has influenced cold ischemic time in certain populations. And why not use drones for organs to be delivered and get inserted. So there is a company called Mission Go that has been doing this. The first one was a kidney delivered to University of Maryland. And since then, there have been several deliveries have taken place, pancreas, kidneys, corneas, most of them to Nevada. And actually, very systematically, they've done even pre and post-flight biopsies, revealing really no change after the flight. Thank you very much, and have a good evening.